So points to remember whenever you talk about acute kidney injury are oliguria will actually precede your rise in serum creatinine. Anuria can be taken at 50 mils per day. Once you've detected it in a patient, you should look for any reversible causes. In general, non-oliguric AKI has a better prognosis. There's only one publication which actually does not favor this point. And recognition of non-oliguric patients is very important as they may require, the statement that I'm using is may, so they may require early dialysis. And longer the oliguria, more is the mortality and more is the severity of the injury. Now, whatever scoring systems we use, they actually help in prediction of mortality and sometimes the further course of the acute kidney injury. So if you have a patient who's got suspected oliguria or anuria, you need to do an hourly monitoring of urine output. You need to assess the catheter position and patency, examine if there's any palpable bladder, look for any flushing, if there is any flushing of catheter that may be required. Establish if there are any mechanical reasons because of which you are getting oliguria and anuria in this particular patient, and try to look for any other causes which can be causative for acute kidney injury. So how do I diagnose it? So this is the KDIGO definition and classification. This is one of the most widely accepted. So in this, the diagnostic criteria would be acute kidney injury would be defined as any of the following, increase in serum creatinine by more than or equal to 0.3 milligram per deciliter within 48 hours, or increase in serum creatinine to more than or equal to 1.5 times of baseline, which is known or presumed to have occurred within the prior 7 days, or a urine volume, absolute urine volume of less than 0.5 mils per kg per hour for 6 hours. Then you have a staging system. If you're talking about AKI stage, then you can use again serum creatinine criteria and urine output criteria. So acute kidney injury stage 1, again increase of serum creatinine by more than or equal to 0.3 milligram per deciliter, or increase to 1.5 to 1.9 times from the baseline. If you've got stage 2, then you get an absolute increase in serum creatinine to 2 to 2.9 times from baseline. If it is stage 3, then you get an increase of serum creatinine of more than or equal to 3 times from baseline. Or an absolute value of serum creatinine more than or equal to 4 milligram per deciliter, or this patient requiring a renal replacement therapy, or in patients who are less than 18 years of age, the decrease in estimated GFR is to the tune of less than 35 mils per minute per square meter of body surface area. When it comes to urine output criteria, you've got a urine output criteria of less than 0.5 mils per kg per hour for 6 to 12 hours. Then it is less than, for stage 2, it is less than 0.5 mils per kg per hour for more than or equal to 12 hours. For stage 3, you have less than 0.3 mils per kg per hour for more than or equal to 24 hours, or the patient is frankly anuric for more than or equal to 12 hours.